Welcome, everyone. Thank you for joining us today. My name is Dr. Louise Ivers. I'm the faculty director here at the Harvard Global Health Institute. It's my pleasure to welcome you to HGHI's Global Health Research and Innovation Speaker Series. This series is hosted by HGHI and designed to showcase the latest advancements in global health research with the goal of fostering dialogue and elevating innovative solutions that advance health outcomes worldwide. Today, our featured speaker is Dr. Mary Rice, but first, I will be introducing you to our moderator. Dr. Satchit Balsari is a member of the Harvard Global Health Institute Faculty Steering Committee. He's Associate Professor in Emergency Medicine at Harvard Medical School and Beth Israel Deaconess Medical Center, and in the Department of Global Health and Population at the Harvard Chan School of Public Health. Dr. Balsari's research and teaching are focused on complex humanitarian emergencies. He's the founding director of the Climate and Health Fellowship at Harvard. He leads the climate platform at the Lakshmi Mittal and Family South Asia Institute at Harvard and is co-investigator on the Harvard Salata Institute's inaugural Interfaculty Cluster Grant on climate change adaptation in South Asia. Over to you, Dr. Balsari. Thank you so much.
Thank you, Dr. Ivers. Thank you, everyone. Thank you for joining us and welcome. Before I formally introduce Dr. Rice, I have a few notes. This session is being recorded through Zoom, as you know. The recording will be made available on the Harvard Global Health Institute YouTube page in the coming days. We will devote time at the end to answer attendee questions. If you have a question for Dr. Rice, please use the Q&A feature at the bottom of your screen. We'll do our best to answer most of the questions that come in. With that, allow me to introduce our speaker today. Dr. Rice is the director of the Institute for Lung Health at Beth Israel Deaconess Medical Center. This is a multidisciplinary respiratory research program that applies advanced statistical and sampling methodologies in clinical populations with chronic lung diseases. It works with multiple US-based prospective cohort studies of both children and adults. A core mission of the Institute is to identify preventable causes of chronic lung disease and to translate research findings into patient care and health policies that improve lung health. Dr. Rice's research is funded by the National Institutes of Health. With that, it's my honor to welcome Dr. Rice. Dr. Rice.
Thank you, Dr. Balsari, for the introduction, and thank you so much to the Harvard Global Health Institute for inviting me to speak today. Let me share my screen. All right. Okay. There we are. Okay. So, with no further ado, I will present to you today work on climate change and respiratory health from epidemiology to intervention. And to start off, I have no financial relationships to disclose. And a little bit more about me. As Dr. Balsari mentioned, I direct a research group that's focused on identifying preventable causes of impaired respiratory health. I'm also a clinician, and I see patients in the environmental justice community of Chelsea in Boston. And very early in my career, I joined the Environmental Health Policy Committee of the American Thoracic Society, which really had a large influence on my work in terms of thinking of how to translate research to policy and prevention. And while I'm no longer on that committee, I now serve on the Environmental Society of Environmental Epidemiology Committee, focusing on similar issues on a global scale. And today I'm going to talk to you about research on climate-related exposures and respiratory health. And I want to point out that this talk is really focused on work that I've been involved with, mostly primary research. And so it's not intended to be an overview of all of the many ways that climate change affects respiratory health. And I will then transition from the epidemiology research to a discussion about interventions, both at the clinical and patient level and also policy level. At a very simply, there are really three main types of lung disease. There's airway disease, affecting the tubes that go that connect the mouth to the lungs, and asthma and COPD are both airway diseases. And as I think this audience will be familiar with, both of these have environmental our environmental lung conditions. And I'll go more into that in my talk today. There's also lung tissue disease. And many of those diseases are occupational respiratory diseases that are also due to inhalational exposures. And lastly, there is lung circulation disease. And so I'm going to be talking about work that we've done looking at inhalational exposures and especially climate-related exposures and these first two types of lung diseases. First, I want to talk about traffic. Traffic is a major source of air pollution, and it is also one of the major sources of greenhouse gas emissions. So in my state of Massachusetts, about 37% of greenhouse gas emissions comes from traffic. And this image here on the left is showing the concentration of particles and gases as a function of distance from a major road. And as you can see here, there is an exponential increase in exposure really close to the freeway that dissipates to background levels as you go further away. And so a lot of our work has looked simply at how close people live to that major source of pollution. We've done work in a cohort called Project Viva, which is based in the Boston area, and recruited mothers and while they were pregnant, and then has followed these kids all the way through their teenage years. And I've worked closely with collaborator Diane Gold in this work. And what's especially pertinent for this cohort study is that we have lifetime exposure data because the US EPA started measuring fine particulate matter right around the time that this cohort study was established. And it's especially important to look at child lung health because kids' lungs are still growing during childhood and then reach a peak in their early 20s. So exposures that affect children during that phase of lung development can have lifetime implications for their respiratory health as they reach adulthood. And in Project Viva, we looked at how close kids live to major roads, which is this first thing on the x-axis, and their lung function in mid-childhood. FEV1 and FVC are two measures of lung function. And we found that kids who live closer to roads, who are more heavily exposed to particles, and especially from black carbon, which is a traffic-related particle, had lower lung function compared to kids who were further away from roads and less heavily exposed. And these effect sizes were about equivalent to a 6-month delay in lung function growth when you compared the 75th to the 25th percentile. We also looked at asthma, and here's an example of some of this work looking at how close kids live to a major road. And those who were in that 100-meter zone where there's that plume of gases and particles had 3 times the odds of asthma compared to kids who live further away. And in Viva, we also found that children who were allergic, who had history of atopy or allergic sensitization, had greater effects, respiratory effects of combustion pollution. And actually, a lot of studies have found that there's this interaction between allergy and exposure to these combustion particles. I was part of a group that looked at the whole literature on traffic related pollution and other forms of combustion pollution and risk of chronic obstructive lung disease. And we reached a consensus based on the mechanistic evidence, the epidemiology, and the clinical plausibility that traffic really causes childhood asthma. It's not just a cause of asthma exacerbation. And that's significant from a policy standpoint because it's much more costly to have a new chronic disease than an exacerbation of a single exacerbation of someone who has the disease. So this is factored into, we're hoping that this work factors into future cost benefit analyses. In adults in the Framingham Heart Study, we can look at not only lung function in adulthood, but the rate of decline in lung function over time. And we can look at the lung tissue because in the Framingham Heart Study, which is a cohort study in the town of started in the town of Framingham in the Boston area, and now includes two different subsequent generations who are now adults. And we can look at the volumes of their lungs on chest imaging, the density of the lung. We can also look at the airways and the presence of emphysema. And in adults, we found not only was their lung function lower in those who are more heavily exposed to particles and traffic pollution, but it also declines more rapidly over time. And we found that the effect size of living close to a major road compared to living further away was 5 milliliters a year, year over year. And this might seem like a small difference, but those effect sizes can accumulate over time. And we found that it was the same effect size as having smoked in the past. We looked at their lung volume on chest imaging and found that those who are living closer to major roads had higher lung volume, which we think is a measure of air trapping, another indicator of obstructive lung disease. And among those who had smoked in the past, there was a higher odds of emphysema on chest CT. And we think that perhaps in the exposure levels that you experience, that this study population was experiencing, that you kind of need a double hit perhaps of the ambient exposure to combustion-related pollution and smoking to see this clinically evident emphysema on imaging. We also looked at lung tissue disease. So in Framingham, there were 2 rounds of chest imaging. There was a cardiac CT that included the middle section of the chest, most of the lung, and then another round, 2008 to 2010, of the full chest CT. And we could look at not frank interstitial lung disease, but scarring of the lung, interstitial lung abnormalities, and the change in those abnormalities over time between scans. So here, the 2 scans that I'm showing, you can see that in each example, there's a little bit more whiteness, there's a little bit more scarring between scans. And we found that traffic pollution, again, was associated with a higher odds of interstitial lung abnormalities and a higher odds of progression of those abnormalities between chest CTs. So what are the implications of these findings on traffic pollution? Well, very near roadway exposures are not directly monitored or directly regulated here in the United States, but they appear to be especially harmful. We found a higher risk of childhood asthma and wheeze among those who are more heavily exposed to traffic. We found lower lung function and a more rapid rate of lung function decline in adults. We found evidence of air trapping and emphysema among those more heavily exposed who smoked in the past. And we also found evidence of interstitial lung abnormalities and progression of those abnormalities over time. Now, in adults, it's challenging to look at risk of chronic disease and these ambient exposures when you often don't have the full story. You don't have the full history of where people lived. And for the Framingham work that I showed you, we just use a snapshot of where they lived during their adult lifetime. So we really need longitudinal histories to characterize lifetime environmental exposures and risk of chronic lung disease in adults. And there's a cohort study in the United States that I'm excited to be a part of called the American Lung Association Lung Health Cohort that's recruiting young adults around the country and is currently enrolling. And we're actually capturing their full lifetime history so that we can look not just at climate-related exposures, but other environmental exposures across the lifespan. All of the work that I've shown you is in the northeastern United States, and I want to note that the traffic pollution levels that I showed you are lower than in most of the world. Traffic pollution levels are much worse in most urban centers of Africa, Asia, and South America. And as regulation tightens up in the US and the EU and Japan, unfortunately, millions of used, highly polluting vehicles are being exposed to low and middle income countries, and especially to the African continent. And this is a major problem that needs to be addressed. And I want to note that my work is not focused outside the US, but this is really a huge problem around the world, and even worse outside of the areas, the research areas that I'm sharing with you today. I now want to shift to a different pollutant, ground level ozone, which is a component of photochemical smog. Not to be confused, it's the same element, but not to be same gas in the stratosphere that protects us from UV radiation. But when it's breathed on the ground, it is very irritating to the lungs. It's formed by a reaction of nitrogen oxides and VOCs in presence of UV radiation. And it is a very well-established respiratory irritant. And it's relevant for climate change because in the setting of heat and sunlight, the formation of ozone is enhanced. And many climate models predict higher ozone pollution, which delays regulatory progress. So here is an example of an image of the US, which is showing predicted changes in high ozone levels due to climate change alone. Here is below on the lower left is work showing the African continent and South America, where in urban areas, especially where there's a lot of precursor pollutants, we're expected to see an increase in ozone pollution due to climate change. So in the Framingham Heart Study, we looked at ozone pollution, and we compared ozone exposure within the green range, which is within within air quality standards, to the yellow range, which is still within the air quality standard, but thought to present a risk for unusually susceptible individuals. And we found that when Framingham Heart Study participants came on their exam days, their lung function was lower when ozone was in the moderate range versus the good air quality range. And we looked to see if there was a threshold effect, meaning that if the exposure was above a certain level, then you would start to see a decline in lung function. But we actually found no evidence of a threshold. And here you can see a linear relationship across the range of ozone exposure, meaning that the higher the ozone level, the worse the lung function across the range. We also looked to see if there were susceptible subgroups, and we looked at obesity specifically because there's a large literature, including mechanistic studies, to suggest that obesity is a risk factor for greater susceptibility, greater respiratory responses to ozone exposure. And it seems to be mediated by IL-33. And we found the same thing in Framingham, twice the effect size in obese adults compared to non-obese adults. And as climate change is leading to more high ozone days in a global population where obesity continues to be a public health problem that is in many places getting worse, I think this is of serious concern. Now I want to shift to temperature. As a pulmonologist, my patients often tell me, doctor, it's really hot outside. I have such a hard time dealing with the summer heat. And in fact, right now, where I'm sitting in Boston, we have a heat dome that's covering the city, and we're about to experience our first heat wave of the season. And I did work that's different from what I've shown you previously. Those other studies were large observational cohort studies. This is a much smaller study, but trying to look at a vulnerable population. So patients who already have COPD, we had them carry air quality monitors with them. So we could look at day-to-day exposure to pollution and temperature and to see how it affected their respiratory health. We followed them for 4 different 30-day periods over 12 months. And during those periods, they recorded their lung function every morning, and they recorded any differences in their respiratory symptoms. And then we could measure their exposure, as I mentioned. Statistically, this is a complicated study because there's a very high degree of correlation within each person, because we have a ton of repeated measures for each individual. So we clustered our data by person and also by month of observation. When we looked at pollution exposure, we found very similar to findings. So what I already showed you, that traffic-related pollution was associated with worse lung function. We especially found consistent associations with nitrogen dioxide, which is a traffic-related pollutant. But I want to, for this piece here, to focus on what we found with temperature. We had outdoor monitors just to measure outdoor temperature in the Boston area. And then we had the personal monitors that the study participants carried with them. And the red here, you can see the personal monitor temperature, which, not so surprising, doesn't vary nearly as much as the outdoor temperature, but you can still see that it's higher on average in the summer months. And we looked at whether there was any change in their day-to-day breathing symptoms. And we found, consistent with what I hear in the clinic, that summer outdoor heat was associated with worse breathing symptoms among these COPD patients. And when we looked at their personally monitored temperature, we found a similar pattern, worse breathing symptoms when it was warm, even in the cold season. There you can see that these blue ones are above the null, but worse in the summer. And this is consistent with a sizable literature looking at respiratory hospitalization. So this is not my own work, but there is evidence both in Europe, in the US, in Asia, around the world, showing a higher rate of respiratory hospitalization during heat waves. That literature is not quite as robust as for cardiovascular causes, but most studies in general have found that the risk is higher. And I think that extra work that these patients with chronic lung disease have to do to get through their day-to-day lives during a heat wave, augmented with any other kind of trigger, including, say, a pneumonia, is going to make them more likely to land in the hospital. I want to talk about pollen. Climate change is lengthening the pollen season. Here in the Northeast, we've seen about a 20-day lengthening in the past 20 years. And in controlled settings, which you can see here, these bar graphs of ragweed production at different CO2 concentrations, you can see what a dramatic rise there is in the quantity of pollen that's produced. So as a result of both higher temperatures and higher CO2 levels, we see faster plant growth and a higher quantity of pollen. And that's not just limited to temperate climates, it affects tropical regions as well. Allergy is very common. It's most patients with asthma have allergy, and others have found that when pollen levels are higher, there's more allergy medication use, more asthma admissions, and there's even some evidence of higher mortality due to COPD and pneumonia on high pollen days. But we did work looking in the general population of young adults. And this is work by Nick Masikas in my group, who looked at fractional exhaled nitric oxide, which is a measure of airway inflammation, type 2 airway inflammation driven by eosinophils and allergic pathways. And he found that even in generally healthy kids, when pollen levels were higher, exhaled nitric oxide levels were higher. And this was not limited to kids with asthma, suggesting that there's an increase in airway inflammation when pollen levels are higher. He also looked at precipitation. There's lots of work looking at extreme weather events and storms, but I want to point out here that climate change, by warming the ocean, increases water evaporation into the air and increases the amount of precipitation in storm-affected areas. So it's not just extreme storms, there's greater intensity of precipitation in many parts of the world, as shown here in the lower right. And in Project Viva, those teenagers in the Boston area, we found that higher levels of precipitation were associated not only with higher exhaled nitric oxide, but also in those who had asthma, also worse lung function. And we have some thoughts on what the mechanism for this might be. It could be mediated by pollen, that some of the effects we already evaluated, or fungal spores and mold that are brought about by precipitation. I have to talk about wildfires as one of the huge respiratory health hazards of climate change. The rate of extreme large wildfires is increasing in all around the world in wildfire-prone areas. I've shown here some examples in Australia and California and Brazil. And this is work not by my group, but there's a very large literature showing that respiratory emissions increase during wildfire events. And you can see here an especially steep slope for asthma. And there's evidence that the particles of the wildfire smoke may be especially toxic for patients with asthma compared to the mixture of particulate matter from other sources. And much like the story with ozone, climate change is really undoing a lot of regulatory progress that has been made in reducing emissions. So here in the US, there's been an improvement in PM 2.5 over the last several decades as a result of cutting back on the particle emissions by motor vehicles and industrial sources. But here in the wildfire-prone part of the US, you can see that there's actually been worsening PM 2.5. And that's primarily a result of wildfires in the US and Canada. I was part of this workshop report looking at the respiratory impacts of wildfires. And I really want to highlight here the conclusions that we made. And I think this is relevant not just to wildfires, but many of the health hazards of climate change. We need to identify effective public health interventions that affect behavior and reduce smoke-related morbidity and mortality. We need a coordinated response to guide local public health efforts. And we made a call for an investment in comprehensive multidisciplinary research that brings together different areas of expertise to address the public health problem of wildfire smoke. So I want to finish my talk by transitioning to a discussion on interventions. So I've shown here a lot of work looking at determinants of health, climate-related exposures, and how they affect lung function and asthma. But we know so much now that we really need to move towards testing solutions in real-world settings and trying to bring those solutions up to scale. And even though we don't have all the solutions yet, I think we really need to talk to our patients about climate change. Even though they may not be empowered to solve this problem, they need to know that this is happening to them and that, for example, in this case, this patient with allergic asthma, that she can anticipate that her allergy symptoms are going to get worse and that the allergy season is getting longer as a result of climate change. Here's one such intervention that I'm working on now. This is a randomized controlled trial of air purification. HEPA filters are known to be really effective in reducing particles, including combustion-related particles, aeroallergens, wildfire smoke. And this is a trial that we're doing in patients with COPD to see if it helps improve their health, with lung function as the primary outcome. Another kind of intervention is the use of respirators and masks. I think we all recall the confusion at the start of the COVID-19 pandemic about whether or not to wear any kind of respiratory protection, who should wear what, where, and when. And I was part of a committee that reflected on the needs for the public, not just for infectious hazards, but wildfire smoke, combustion pollution. And we recommended a new government entity for guidance on respiratory protection by the public so that we can anticipate these hazards because we know it's only going to get worse, and to give guidance for the public on when, for example, they might wear an N95 when going outside. I think we need to pivot our research towards translation to policy. This is a really elegant study on the left looking at the real-world experience in the 1990s during the Atlanta Olympics, when the city of Atlanta restricted traffic and there was a dramatic decline, not just in traffic counts and pollution, but also in childhood asthma claims. In Project Viva, we've looked at how air quality has improved as a result of regulation and have found that lung function improved among kids who experienced a reduction in their exposure. So can we start to quantify the value of these kinds of climate mitigation efforts at a local scale that will help inform decision makers? I think there's a need for the medical community to add their voice, to add the voice of science and medicine to energy and transportation policy discussions. We may not normally think of these as being in our wheelhouse, but they very much are affecting the health of our patients. And I think it's important for us to bring these health benefits of reducing combustion pollution exposure, for example, to the attention of energy decision makers at our institutions, at the policy level. COP28 is the Global Climate Conference, and this year in the UAE, for the first time, there was a health day. And these health days are going to continue in the future. And I think this will be a new platform for the medical community to engage on climate policy discussions at the global scale. And here I'm showing an image of what the ISEE put together when I went to this meeting, was meeting with decision makers. We focus on the health benefits of climate mitigation, healthier air to breathe, increase energy security by having reliable, renewable energy for healthcare facilities, healthier plant-based diets, and healthier cities and transportation programs, systems, when people are more active and exercising more and less heavily exposed to traffic. That's good for health. For anyone on this call who is interested in climate change and health research, I want to bring to your attention CAFE, which is a convener of the climate change and health research community. It's based at BU and the Harvard School of Public Health and offers resources and data sharing for the climate change and health research community. And just to conclude, motor vehicle pollution, like tobacco smoke, injures the airway and the lung tissue. And patients with chronic lung disease, including those with asthma and COPD, are harmed by climate change through higher temperatures, amplified pollen, and worsened wildfire seasons. And patient-level and policy solutions are urgently needed to address the ongoing respiratory harms of fossil fuel burning and to achieve a rapid and just transition. I'd like to thank my collaborators at Beth Israel and the Harvard School of Public Health, and I'd like to thank you all for joining this call, and I look forward to your questions. Thank you.
Dr. Rice, thank you for that very sobering thought. With rising temperatures and the wildfires and the development that is going to continue at the rapid pace as it does in the developing world, especially the juxtaposition of traffic and roadways to asthma is going to be such an incredible challenge for respiratory health in the developing world. One of your opening slides had that very remarkable graph of distance from roadways. And I was thinking about the global south, where just almost everyone lives on the roadways. There is no distancing from the roadways. The cities are so densely packed, so congested. And you've begun thinking about these applications overseas as well, as we have global health conversations on campus. What might be the policy levers for health systems to think about in the global south? How do we take all this incredible work that has been done here, the science work that has been done in the US, but try and influence policy in the global south? I ask this in the context of the fact that the built environment of the global south 20 or 30 years from now has largely not yet been built. The vast majority of how these cities will be built is yet to be seen. And if we continue on the path that these cities are on right now, I cannot imagine these children being able to breathe at all. So what might your advice be?
Yeah. Well, I want to start off by recognizing that I'm not, my research is the focus on the US, right? And I don't want to pretend to know what will solve this problem in the global South. I think that we need partnerships on the ground to solve this problem at every level. And that's across the world, right? We can't, as researchers say, this is the answer and this will solve it for someplace far away where I don't even know the community, right? I think that for traffic-related pollution, we can go a long way through urban planning, which is, I think, what you're alluding to, Dr. Balsari, that there's so much need for to design cities and spaces in ways that cut down on traffic and enhance quality of life, right? So if we can focus our future design of urban spaces in ways that will meet community needs, cut that congestion of traffic in the dense urban areas, and focus on investing in parks and active transportation, biking, for example. That is not only good for the air quality, but it's good for community. It's healthy to exercise. The Netherlands historically has been very, very deliberate in their urban planning, and they decided a long time ago to really invest in bicycle infrastructure. And as a result, the Netherlands is people in the Netherlands live a very active lifestyle and generally commute by bicycle to work. Now, of course, none of this can happen overnight. And so I think when I would like to see largely as a research community focused on the climate change and health crisis, we need to think about patient level interventions, things like the air purifiers I was talking about, or respirators, like what should clinicians tell their patients and what interventions actually work? And that answer might be different in different cultural settings in different parts of the world. Like, what are people actually going to be able to wear and be adherent to lead to a health benefit? So we need the patient level work. We need to be able to warn communities, but then they also need to be able to respond to that warning in some way. So, and in order to be able to do that, we need community level readiness to ensure that the most vulnerable people can be protected. And so in order to make cities healthier, to cut back on combustion-related transportation, to respond to the inhalational hazards of climate change, we really need complete rethinking about our dependence on fossil fuels, right? And to really cut that is going to require a tremendous restructuring of our economies. In terms of the research and health community, I think we also need to, in addition to communicating what we already know about the health effects of climate change, we really need to focus now on developing and testing solutions.
Thank you very much. You raised very important points about these tight relationships between health and environmental hazards from a built environment. I think your point about getting in front of policymakers and demonstrating that these linkages already exist could shape future policy, urban planning policy. Reminds me of a conversation a couple of days back on campus, where a researcher from the University of Oxford had shown that slum rehabilitation buildings, the way they've been designed and built in the global South, actually make people a lot more miserable because of the nature of the design itself. And they were a lot hotter and was impacting morbidity and mortality. And the policymakers said, no one told us this. And we design it differently. And so I think there's a lot of power in the work that you've done even domestically. It has such important translational impact overseas. We have several young audience members here that have two interesting questions for you, and I will ask both together. One has asked, for teens and youth, what are few ways or the best way to help their community and educate their peers that do not believe that this is an important issue? And an undergraduate student has asked if, as an undergraduate student interested in pursuing a career in environmental health, what is the advice you have for me to get into the field?
Okay. So the first question was about convincing someone that this is a big issue. And I think, was that the question, Dr. Balsari? To convince someone that this is something we should be worried about?
Yes.
Well, I think sometimes we have to point to the extremes, right? The heat waves, all the work that I showed you was really actually not about the extremes. I was showing you work on day-to-day variability and temperature and typical precipitation levels and stuff that that's going to affect health. But the big plumes of wildfire smoke and the frequency with which those fires are happening, the heat waves, the data on the pollen seasons getting longer, those are really concrete trends. And I think I'm hopeful that the public in the last couple of years is shifting a bit away from doubting that climate change is happening to more disagreements about what the solution should be. The next question was about how to get involved. So we need everybody as all sorts of experts to engage on this, right? So I'm engaging as a pulmonologist, as a researcher. We need health economists. We need the business community to partner with the research community. There's so many different ways to come at this that I don't want to say that there's just one answer. I think increasingly there is a forum for engagement in almost any discipline of the field. But I would say for medicine, getting a master's in public health is helpful. Getting some research experience under your belt, and then to try to find yourself a mentor that you look up to that does work similar to what you do.
Dr. Rice, thank you. As we wrap up, a concluding message from you, as we sit here in Cambridge with the temperature creeping up to 89 already, it's going to get hotter. It is hot and humid in many parts of the world. What is your advice? What should scientists in our community be thinking about in terms of respiratory health as we look at a warming world?
So I would actually like to end with what I think is a powerful analogy. And that's that fossil fuel burning is like tobacco that fills the lungs with toxic smoke. And even though the heat is invisible, even though the pollutants are mostly invisible to the naked eye, they impair the health of the entire population that's breathing that air, and especially children and the elderly and those with chronic lung disease are affected. And so I want to make a comparison of tobacco and fossil fuel use, if I may, because in both cases, it took the medical community some time to realize that it was a cause of death. But in both cases, the science is now clear. Both cause lung cancer, as declared by the WHO. Both cause asthma attacks and COPD exacerbations. And as I've shown, both play a role in causing obstructive lung disease. Children are especially vulnerable to tobacco and fossil fuel pollution, and their lungs are still developing. and the adverse health effects of early life exposures could have lifetime implications. Powerful economic interests are at play and have sowed doubt about these health effects. But for tobacco, the medical community ultimately came together with a resounding and clear message that tobacco kills. But for fossil fuel burning, those powerful economic interests are still in charge of the messaging. And so as medical professionals, we're caregivers, we're scientists, and messengers. And we're already treating the health effects of climate change, and we can speak about this issue from our hearts. We're trusted voices in society, and in partnership with the communities that we serve, we can be agents of change.
Dr. Rice, thank you for your wise counsel, and thank you for your time today. Thank you to our virtual audience for your participation and engagement. The link to this talk has been dropped in the chat channel. As we wrap up, I encourage you to keep an eye on our website to learn about our next Research and Innovation Series event, which will return in the fall. Thank you all again, and have a wonderful rest of the day. Remember to stay cool if you are under the heat dome today. Bye.
Thank you.